Right. Hello, everyone, and thanks for joining. Highlights from the 2026 CPT Code Set Changes webinar. My name is Jordan Leibovitz. I am part of the marketing team here at IMO Health. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Along in that follow-up email, you will receive a CEU certificate and then also a PDF of the slides. Throughout the session, all attendees will be in listen-only mode, but if you have any questions, please type them into the Q&A section in your Zoom webinar console. We will do our best to get to as many questions at the end of the session, but if for any reason yours is not addressed, we will follow up with you afterwards. We like to keep things interactive, so throughout the webinar, we will be launching poll questions for you to answer. And we want to preface this before we begin by saying this year has a lot of changes, so the session could run over an hour. If it does, feel free to drop off when you need to. Either way, we are sending you everything you need. Today, we have my two lovely colleagues from IMO Health, our Vice President of Global Clinical Services, June Bronnert, and our Director of Global Clinical Services, Shelly Jude. So with all of that being said, I'm going to pass it on over to June.
Thank you, Jordan, and welcome everyone. For over 3 decades, since 1994, IMO Health has been revolutionizing data capture at the point of care. Our comprehensive clinical terminology and code mappings allow clinicians to document in their own words while seamlessly capturing essential clinical details and billing codes. As we know, codes change, and we are going to focus on the 2026 CPT code changes for the next hour. So let's get started as we have a lot to cover. And here are the changes by the numbers. There's a total of 418 code changes overall with many guideline changes. While we wish we could cover all updates, we have selected the most relevant areas to share with everyone. But before we dig into the details, we have 2 polling questions. Jordan, can you review the polling questions?
Awesome. Okay, so before we get into the nitty-gritty for what you're all here for in the CPT code sets, I want to ask you a few questions regarding denials and rework related to surgical workflows. So what best describes your organization's experience with site of care related denials or rework for surgical procedures? Is it we frequently see denials or lost reimbursement due to inpatient only or site of care issues? We see issues occasionally, but they require significant manual review. We rarely see site of care related denials, or we don't have any good visibility into this today. And then another one on how does your team currently handle missing or incorrect laterality, right or left modifiers on surgical CPT codes? Is it frequent change, review edits, or denials that require manual coder intervention? Occasional issues typically caught during charge review, minimal issues due to strong front-end controls, or not sure, and we don't actively track this. I'm going to give it a few more seconds, and then I will end it. All right. June, if you don't mind going to the next slide. So what's interesting about these polls is they highlight something we see across a lot of organizations. So whether it's missing laterality modifiers or site of care decisions like inpatient versus outpatient or ambulatory surgical centers, the common theme is that these issues are often caught after the fact. So during charge review, denial work queues, or in the appeals part. So the challenge is that by the time the teams see these issues, they're already creating rework delays or even lost reimbursement. So the question really becomes, how do we shift that work earlier in the process? So something our teams have been working on is procedure validation sets. It will be launching early next year. So instead of relying on downstream cleanup, validation logic is applied upstream in the workflow during scheduling and charge capture. So required modifiers and site of care eligibility are confirmed while this case is still being built. So the goal is simple: catch issues early, reduce the manual intervention, and then protect that surgical reimbursement. So stay tuned. Early next year, we'll have more information for you, but we wanted to kind of get this out there. So with this in mind, I'm going to pass this over to June, who will walk through the actual CPT changes.
Thank you, Jordan. Let's start with changes to the vascular section. Before we begin with code changes, here's a quick review of the thoracic aorta anatomy. The aorta is the largest artery and for 2026 has extensive changes in both guidelines and codes. The changes are related to the anatomical sites of the thoracic aorta. The ascending aorta, aortic arch, and descending thoracic aorta make up the three main components of this large vessel. Note the aortic arch includes the brachiocephalic vessels such as the innominate artery, left common carotid artery, and left subclavian artery. And on the next slide, we will begin to look closer at the changes for endovascular repair of the thoracic aorta. The subsection and code titles have been revised to remove the word descending. By removing the word descending, the codes now apply to all the anatomical sites of the thoracic aorta, not just the descending. And before we look at the actual code changes, I wanted to highlight a few important guideline revisions, but I highly recommend a review of all the guideline information due to the many changes, as we will see on the next slide. Thoracic aortic endovascular services are for treatment of conditions such as aneurysms, aortic dissections, or even traumatic disruptions to the thoracic aorta. Services involve placement of an endograft into the various anatomical sites of the vessel. The location of the placement of the endografts may also be referred to as the treatment zone, since CPT defines the treatment zone as those vessels containing the endografts. While there may be various configurations of the endografts, there are three main orientations. And those three main orientations of the graft are as follows: an aortic tube device, which does not cover the left subclavian artery, a parallel stent into at least one of the brachiocephalic vessels that runs along the side of the placed aortic tube device, a fenestrated and/or branched modular system, and this is typically an aortic tube device with fenestrations that allow for additional stent graft extensions to be placed into at least one of the brachiocephalic vessels. The anatomical placement of the endografts is a key factor for reporting these services, as the code selection is based upon the most proximal extent of thoracic aortic coverage, as we'll see on the next slide. And while this slide is wordy, I wanted to highlight a few of the new and revised codes. Codes 33880 and 33881 were revised to reflect the anatomical site change along with the endograft's orientation. Code 33880 represents an endograft that covers the left subclavian artery, while 33881 states the endograft does not cover the left subclavian artery origin. Code 33882 is new and reflects the modular system endografts. The description also includes the vessel level placement. Note the placed from the level of the left common carotid artery to the celiac artery on the slide. Another new code related to this subsection is code 35602, bypass graft with other than vein carotid contralateral carotid. This code was added to reflect potential services which may be required when placing the thoracic aortic endografts. And as the code descriptors for this section reflect the anatomical changes and the orientation of the grafts, it will be important to review the descriptions when reporting the services. And next, we'll briefly look at the related deleted codes. Here are a few examples of the deleted codes, but wanted to highlight the radiological services and guidelines that were deleted. The changes are due to the subsection guidelines indicating what services are included with the endograft repairs. And next, we'll look at changes impacting Category 3 codes. Baroreceptor activation, or BAT, is typically used to treat heart failure and hypertension resistant to treatment. Within the walls of the carotid arteries, baroreceptors are present and help regulate various physiological functions such as blood pressure and heart rates. The baroreceptors send signals to the brain, which then sends signals to the heart to help maintain balance of the circulatory system. The BAT procedure involves implanting an electrical device system, the lead impulse generator, to facilitate those baroreceptor signals to support a homeostatic circulatory system. Prior to 2026, services related to that were reported with Category 3 codes, but as you can see on the slide, they have been deleted, and starting in 2026, new codes in the surgical section have been added for implantation, revision or replacement, or removal of the system or the system components, as you can see on the slide. As the BAT system also requires monitoring like other devices, such as pacemakers, defibrillators, 2 new codes have been added for the ongoing monitoring or interrogation of the device, as you can see on the slide. Next, we will review the last Category 3 changes in this section. One code 0631T will be sundown as of 2026. There is guidance for which code should be reported now for this procedure, which is code 93998. 2 new codes were added for an emerging procedure, aortic wall stabilization. This procedure involves a local drug delivery with the goal to stop small to medium-sized aneurysms from growing. The medication is delivered to strengthen the weakened aorta. And while there are existing codes 34701 and 34713, which at first appear to appropriately represent aortic wall stabilization, there are enough differences to warrant new codes. For example, code 34701 includes an endograft deployment, while code 34713 does not include an aortic wall stabilization drug. Due to these differences, 2 new codes are added to Category 3 as shown here on the slide. Now let's turn our attention to cardiology changes. This section also has many code and guideline changes. The guideline changes are intended to provide clarity for proper use of the percutaneous coronary intervention, or PCI, procedures and code families. PCI is a broad term that can encompass different methods, techniques designed to restore blood flow through the coronary vessels, either the native vessels or grafted vessels. The PCI codes are built on a progressive hierarchy of services. The more intensive services include the less intensive services. We will spend a bit of time reviewing the various changes to this section, but as we only have so much time, I again encourage you to further review the guideline and the code changes. But before we dig into these changes, we will review terminology revisions, starting with CPT's definitions. The major coronary arteries are defined as the left main, left anterior descending, left circumflex, right and ramus intermedius arteries. Artery branches are defined as up to 2 coronary artery branches off a main artery, except for the left main and ramus intermedius coronary arteries. For reporting purposes, they do not have recognized branches. Another important term is coronary segment. Coronary segments are specific portions of major coronary arteries and their branches. The CATH PCI database has identified 39 coronary segments as part of the CATH PCI registry reporting program. The CATH PCI registry is one of the National Cardiovascular Data Registry programs. In addition to the examples shown on the right-hand side of the slide, other examples include mid-right coronary artery conduit segment or distal right coronary artery conduit segment. CPT has also included a new illustration with the 39 various segments identified for 2026. We will review the next coronary bypass graft refinements. Each coronary artery bypass graft represents a major coronary artery. This definition was updated to reflect a change in terminology from coronary vessel to major coronary artery. The guidelines now state if the bypass graft is sequential or branches with more than one distal anastomosis, this still represents one graft. Note, this is a change from prior guidelines that stated a branching bypass graft, for example, a Y graft, represents a coronary vessel for the main graft, and each branch off the main graft constitutes an additional coronary vessel. A couple of guidelines related to reporting of these codes are shown in the purple box. A PCI performed on a major coronary artery or major coronary artery branch by access through a bypass graft is reported using the bypass graft PCI codes. Bypass graft PCI codes include the use of coronary artery embolic protection devices when performed. One more area of terminology to review is coronary lesion. A coronary lesion is typically a buildup of fatty plaque within a coronary artery. Identifying the number of coronary lesions will be important to determine the most appropriate code, as we will see in a bit. So what is considered a single lesion? A single and distinct lesion is defined as starting at the proximal end of the PCI targeted lesion and ends at the distal end of the targeted lesion. And just to be clear, a targeted lesion is the coronary lesion that the PCI is intending to remove or resolve to reestablish blood flow throughout the vessel. Coronary lesions may be considered multiple when geographically separated, such as two different major coronary arteries, each having a lesion. Keep in mind, a single distinct coronary lesion may involve multiple coronary segments and may extend from a major coronary artery into one of its branches or from a bypass graft into the subtended vessels. The guidelines identify many different scenarios for when a coronary lesion may be considered single or multiple. Review the guideline changes as well as the anatomy of the coronary vessels to determine the number of coronary lesions, as we will see with code changes related to stent placements. Proper reporting involves knowing the number of coronary lesions. But before we look at the changes for stents, let's start with the angioplasty and atherectomy. And a reminder that an angioplasty is the opening of the vessel, typically performed with a balloon and/or laser. And for 2026, the code title revisions now includes "and" along with branches. The changes are highlighted in green on the slide, and the changes to the atherectomy codes is like the angioplasty. Again, this code is for major coronary artery and/or its branches. And as we progress in service intensity, we will now look at changes to the stent placement. Here you can see the side-by-side code title revisions for both the angioplasty atherectomy codes when performed with stent placement. The coronary lesion and coronary segments was added to the title for code 92928. Code 92933 is used to report an atherectomy with an intracoronary stent, which includes a coronary angioplasty when performed, was also a revised code. Upon restructuring of codes, it became clear a new code was needed. And while there are two new codes listed here, the code 92930 was added due to the restructuring of the stent placement codes. Code 92930 is part of the code family 92928 through 92930. And just as the revised code 92928, code 92930 includes similar terminology related to coronary lesions and stent deployment and coronary segments, but notice it's two or more for each of those. The new code 92945 is for PCIs performed for chronic total occlusions. This code is part of the code family 92943 through 92945, and determination of a code in this code family includes the approach to the intervention that we will look closer at on the next slide. Code 92941 first is for emergency situations and should not be used for non-emergency situations. The occlusion for the emergency could be either a total or a subtotal occlusion. And while the guidelines indicate various procedures are included with code 92941, this procedure may include any combination of stent placement, angioplasty, or atherectomy. And just as we saw on the previous slide, a chronic total occlusion of a coronary vessel is present when there is no antegrated flow through the true lumen. And the code selection always includes the approach to opening the lumen as to whether it's antegrade or antegrade and retrograde. So just as with code 92941, this procedure includes many combinations, including the stent placement, angioplasty, or atherectomy. And while we touched on some guideline changes earlier, we'll now take a closer look in this area, starting with a few high-level guidelines. The less intensive services are included with the more intensive services codes, as we saw with the angioplasty and atherectomy included with stent placements. And other services, just as contrast injections and fluoroscopy guidance, may be included. Going a bit deeper, let's look at the major coronary artery refinements. Clarification for when to report one base code from the PCI family codes is part of the changes. Only one base code from the PCI family may be reported for revascularization of a major coronary artery and its branches. A similar guideline is in place for revascularization of a coronary artery bypass graft and its subtended coronary artery and those branches. The PCI base codes are shown on the slide. And as we previously reviewed guidelines for the bypass graft, that information is not repeated on this slide. This slide shows additional changes for when one segment of a major coronary artery is treated through the native circulation and treatment of another segment of the same artery requires access through a coronary artery bypass graft. The intervention through the coronary bypass graft is reported separately. Again, a thorough review of the guideline changes should occur to facilitate proper code reporting. And now let's look at changes for stents and lesions. Knowing the number of coronary lesions and segments along with the method of treatment is key to facilitating proper code reporting for stent placement. Here's a quick reminder for the multiple coronary lesions. The multiple can occur within one major coronary artery, but the geographic separation is required. And if the lesion is just an extension, then it is considered a single distinct lesion. The guidelines address many different scenarios for when lesions are considered single versus multiple. And as you can see on the slide, the difference in code title descriptors related to segments, lesions, and stents. The guidelines also address coding for bifurcation lesions and is shown on the right-hand side of the slide. Next, we will review procedures which may also be performed with PCIs, starting with the coronary flow reserve measurement. 93571 and 93572, the intravascular Doppler velocity and/or pressure reserve measurements, along with 92972, the percutaneous transluminal coronary lithotripsy, are add-on codes for reporting procedures performed, in addition to the coronary and bypass graft diagnostic and PCI procedures. Here are the changes to codes 93571 and 93572 as both codes were revised. And on the next slide, we'll see changes to the coronary lithotripsy. While the code itself did not change, the notes indicating when to use the code have been revised throughout this section. And it's important to note that the guideline which indicates that this code may be reported once for each major coronary artery or bypass graft. The last area we will review for this section are the Category 3 code changes. New Category 3 codes have been created for remote cardiac contractility modulation or CCM services, along with hemodynamic inferior vena cava monitoring. This slide shows the new codes. The CCM codes are based upon professional versus technical components, and each code identifies the services that are included within those different components. Codes for hemodynamic inferior vena cava monitoring describe the placement of wireless IVC sensors to perform long-term hemodynamic monitoring, along with the remote monitoring of the device. And now let's turn our attention to lower limb revascularization changes. Just as with the other sections, the guidelines underwent extensive changes. Almost all were deleted due to the extent of change. We will look closer at these areas over the next few slides, but let's start with changes to the vascular territories. A vascular territory is a collection of anatomically related arteries for coding purposes. Code 37254 through 37299 are divided into 4 vascular territories: iliac, femoral and popliteal, tibial and peroneal, and inframalleolar. These territories contain vessels that may be treated, and the 4 territories each have specific guidelines in addition to the guidelines that are applicable to all territories. The next slide contains samples of coding changes for the iliac vascular territory. Here you can see how the lesion stratification is reflected in the CPT code descriptions. Note the terminology of straightforward and complex, which we will further discuss. The code descriptions also shows the less complex services being included in the more complex services. See how code 37258 includes a stent placement and angioplasty. Each of the 4 vascular territory code ranges reflect a similar pattern. And now let's look closer at the lesion stratification and other aspects for code selection. For lower extremity endovascular revascularization treatment, a straightforward lesion is a stenosis, and a complex lesion is an occlusion. The occlusion must be 100% to be considered complex per information from the American Medical Association. All other percentages are considered a stenosis, which is straightforward. CPT coding in this area considers angioplasty, stent placement, atherectomy, and/or intravascular lithotripsies when selecting the appropriate codes. 2 new codes are added for 2026 as shown on the slide. And note the lithotripsy is reported per vessel, not lesion. Overall, lower extremity coding is based on the vessel that is treated, the technology or technique used to treat it, and the complexity of the lesion. We are highlighting a few that we have not already touched upon with guideline changes, and the guidelines indicate which other procedures are included in the codes for lower extremity revascularization. And here are a few, such as accessing and selectively catheterizing the artery, crossing the lesion, performing the endovascular intervention, imaging, embolic protection if used, and then standard closure methods of the puncture site. One existing guideline that will remain, mechanical thrombectomy and/or thrombolysis in the lower extremity vessels are sometimes necessary to aid into restoring the blood flow to areas of occlusive disease and are reported separately. The revised guidelines also indicate when a diagnostic lower extremity arteriography may be separately reported. When treating multiple vessels in the same vascular territory, select one primary lower extremity revascularization code. If additional vessels within a vascular territory are treated, the service may be reported with add-on codes. Again, please review all the guidelines in this section due to the various changes. And now I would like to turn the presentation over to my colleague, Shelly.
Hello, everyone. I'm going to start with a section of radiology. We will be going over irreversible electroporation, CT cerebral perfusion and CTA, radiation oncology, laser ablation breast tumor, tissue displacement for thermal ablation, and tumor treating field dosimetry. Next slide, please. Irreversible electroporation percutaneous solid tumor ablation. Generally, there are different CPT codes for each method and each organ because the work for each is different. Ablation is performed with many different types of delivery systems, from radiofrequency and microwave ablation, which burns the tissue, cryoablation, which frees the tissue, and ultrasound histotripsy and magnetic resonance, which guided focus ultrasound physically damage the tissue. Ablation is performed in many different organs, including liver, kidney, lung, bone, thyroid, prostate, brain, and others. IRE destroys tissue in a different manner than other ablation techniques. It works by applying a strong electrical field between the pairs of electrodes to the target zone, which creates irreversible pores in the cell membranes, which then cause these cells to die. IRE is a non-thermal technique, so it can be used near a sensitive structures like blood vessels and bowel, and it provides more precise targeting with less collateral damage. Next slide. Percutaneous IRE. Percutaneous IRE was previously reported with a single organ nonspecific category 3 code 0600T. Note that there is a separate category 3 code for open IRE, which is 0601T. Effective January 1, 2026, 2 new organ-specific category 1 codes have been established for percutaneous IRE. Liver 47384, prostate 55877. Revision of Category 3 Code 0600T, ablation irreversible electroporation, one or more tumors per organ, other than liver or prostate, including imaging guidance when performed percutaneous. The new IRE codes bundle imaging guidance because imaging guidance is always used. Parenthetical notes have been added following both codes 47384 and 55877 to direct users to code 0600T for percutaneous IRE of tumors and organs other than the liver or prostate. Category 3 codes should still be reported for any other use of IRE outside the liver or prostate, for example, the pancreas and or kidney. There wasn't enough literature and or usage for sufficient to establish a category 1 code. Next slide. CT cerebral perfusion analysis rationale for new codes. Code 0042T, CT cerebral perfusion analysis with contrast, including post-processing with determination of cerebral blood flow volume, and mean transit time. Code 0042T is the oldest Category 3 code in the book. This service is now widely performed across the U.S. and has ample literature support. The panel determined that conversion to a Category 1 code is appropriate. CT cerebral perfusion analysis is frequently performed in conjunction with CTA of the head and neck, especially in comprehensive stroke centers to help select patients for stroke intervention. Next slide, please. Cerebral perfusion and CTA head and neck new codes. New Category 1 codes 70471 through 70473 were established to report CTA and CT cerebral perfusion of the head, neck, and brain. Category 3 code for CT cerebral perfusion 0042T was deleted. Parenthetical notes have also been added and or revised to remove all related references for code 0042T and to provide users instructions for reporting these new codes. Next slide, please. Cerebral perfusion and CTA head and neck related revisions. 70496 CTA of the head may not be reported with neck CTA or with the new bundled CTA head and neck codes. Use the bundled code. May not be reported with a non-contrast head CT, which would be reported with 70450, and may be reported with a new add-on CT cerebral perfusion code. 70498 neck CTA may not be reported with head CTA or with the new bundle CTA head and neck codes. Use the bundle code, and may not be reported alone with the CT cerebral perfusion code because it's only the CT cerebral perfusion. Next slide. Radiation oncology, treatment delivery. Rationale for revised codes. Numerous changes have been made throughout the radiation treatment delivery services subsection to redefine the complexity of services provided and replace outdated codes. The goal was to also replace the long-standing G codes that never went through the RUC process, G6012 through G6015. Treatment delivery codes are primarily used to report technical services. Treatment management codes are used to report the professional services. Existing codes have been revised with a new hierarchy of levels of service, levels being 1 through 3, to differentiate the time and effort involved in different types of RO treatment delivery services. These new codes replace the previous hierarchy of simple, intermediate, and complex, which had become outdated. Also tried to clarify which codes may be used to report professional and technical services. Updates to the existing table in the CPT code set guidelines have been revised to define commonly used terms, ISO center, active motion management, or surface guidance. Next slide. Radiation oncology treatment delivery deleted codes. CPT code 77401 has been deleted because it included previous language that is no longer being used to differentiate levels. Code 77385 and 77386 have been deleted, intensity modulated radiation therapy treatment delivery codes. And code 77014 has been deleted, CT guidance for placement of treatment fields bundled with other services. Guideline revisions include levels of complexity have been defined to differentiate different work, and these levels replace the long-standing simple, intermediate, complex, differentiated that seem to no longer be useful. Next slide, please. Laser ablation of breast tumor rationale for new codes. Laser energy can be used to ablate breast tumors, benign and malignant, destroys cells with heat energy, requires image guidance, therefore imaging guidance is bundled, and FDA approval. Yes for benign breast lesions, no for malignant breast lesions, still under investigation. Next slide, please. Laser ablation of breast tumor. This is a picture of the procedure, 2 probes used, one to deliver energy via laser and one to measure the temperature. Next slide, please. Laser ablation of breast tumor rationale for new codes. New Category 3 codes 0970T and 0971T have been established to report laser ablation of the breast tumor tissue. Code 0970T describes ablation of benign breast tissue tumor, and code 0971T describes ablation of malignant breast tumors. Parenthetical notes were added following codes 19105 and 0581T, directing users to these new codes for laser ablation. Next slide. Tissue displacement for thermal ablation procedures, rationale for new add-on codes. 3 new Category 3 add-on codes, 1022T through 1024T, have been established to report percutaneous tissue displacement during ablation procedures. Several parenthetical notes have been added to instruct users on the correct use of the new codes. Note, the work of the ablation is separately reportable. Most ablation procedures work by using heat or cold to destroy the cells in the target zone. It is very important not to extend the target zone and injure adjacent normal tissue, such as colon, small bowel, or stomach. To provide protection, these normal tissues can be displaced away from the target tissue by injecting fluid or carbon dioxide. Protects the normal tissue from thermal damage delivered to the tumor. Next slide. New add-on codes. New add-on codes 1022T, percutaneous tissue displacement, any method, including imaging guidance, intra-abdominal, pelvic structures, list separately in addition to code for primary procedure. Image shows tissue from the bowel displaced by injecting fluid, the ablation then performed and separately reported in this instance with CPT code 49405, which is image-guided fluid collection drainage by catheter, visceral, or percutaneous. Next slide, please. Tissue displacement of thermal ablation procedures, new add-on codes. New add-on codes 1023T, intrathoracic structures. There are parenthetical notes that should be referenced. And new add-on code 1024T, soft tissue, in addition to code for primary procedure. Next slide, please. TTF dosimetry rationale for new code 1025T. New Category 3 code 1025T has been established to report alternating electric fields dosimetry. Code 1025T describes the dosimetry and delivery simulation, modeling targeting the tumor and selected margins, personalized for each patient. The treatment is then delivered continuously by an electric current over an extended period of time. Treatment is self-administered through durable medical equipment. There is no code for the actual treatment because there is no physician work. Not related to the radiation oncology dosimetry codes, and any diagnostic imaging such as CT, MR is separately reported. Next slide, please. TTF dosimetry new code 1025T, alternating electric fields, and does give a parenthetical note. Do not report 1025T in conjunction with 77280, 77285, 77290, and 77300. Diagnostic imaging for computed tomography and magnetic resonance imaging simulation imported into the therapy treatment planning system may be reported in addition to the alternating electric field dosimetry. Next slide, please. Now we're going to look at otolaryngology procedures. We will be going over hearing device services, middle ear implants, cryolysis therapy for sleep apnea. Next slide, please. Hearing device services rationale for changes. Existing codes for these services were developed pre-1990. Existing codes for the selection and fitting of hearing aids no longer align with contemporary practice and technology. For 2026, 12 new codes and parenthetical notes established. Codes 92628, 92629, 92631, 92632, 92634 through 92639, and 92641 and 92642 describe services primarily related to the provision of air conduction hearing aids. Following a diagnosis of the hearing loss, these codes apply to the full range of services specific to air conduction hearing aids. These services fall into 6 major categories: hearing aid candidacy determination, hearing aid selection, hearing aid fitting, follow-up services after fitting, objective verification, which is typically performed at the time of either fitting or post-fitting follow-up, and it can be performed through behavioral verification, probe microphone measurements, and/or electroacoustic analysis. Also, assistive device services is included. Next slide. The new hearing device services table lists the major categories of services, their associated codes, and assigned times. Table is located in the evaluative and therapeutic services subsection in the special otolaryngology services section following the new codes. Verification is not always performed. Behavioral and probe microphone verification and add-on services that are always performed with fitting or post-fitting follow-up services. Electroacoustic analysis verification can be performed as a standalone service and requires specialized equipment. Do not include the time spent providing verification services when calculation total time for evaluation, selection, fitting, and follow-up services. Next slide. Middle ear implants, new codes rationale. 5 Category 3 codes 0951T through 0955T have been established to report total implantation revision of or replacement with or without mastoidectomy, replacement only, and removal of active middle ear hearing implant, sound processor, and all implant components. Designed to address the need to identify the implantation revision or battery replacement of a totally implanted active middle ear hearing implant device. Existing CPT codes differ because they involve use of partially implanted hearing devices. Next slide. Middle ear implant new codes are listed on this slide. New codes for the middle ear implants include niche service offered primarily by an otologist, not a bone-anchored hearing aid, osseo-integrated hearing implant, and the middle ear implants are fully implanted, treats sensorineural hearing loss, uses part of the native middle ear, which includes the malleus, head of incus, and stapes. Next slide. Middle ear implants essentially functions as implanted hearing aid. It amplifies the function of the middle ear. Natural middle ear provides over 20 times amplification. These devices magnify that amplification by replacing the malleus and incus. Denude incompatible joint, separate incus from stapes, remove long process of incus, and connect driver to stapes. Codes only apply to fully implanted devices. The sound is then sent from the malleus incus to the processor. Next slide, please. Cryolysis therapy for sleep apnea, rationale for changes. Before 2026, there were no existing codes to report the use of cryolysis therapy for sleep apnea. 3 Category 3 codes, 0978T, 0979T, and 0980T, were established to report cryolysis therapy for conditions such as moderate to severe sleep apnea. There are several parenthetical notes which were established throughout the CPT code set to instruct users on the correct use of the new codes. Next slide, please. Cryolysis therapy for sleep apnea. The new codes are listed on this slide, and there is directive underneath that says do not report 0979T, 0980T in conjunction with 0978T. Next slide, please. Cryolysis therapy for sleep apnea. The patient has sleep apnea, may not be the only procedure that is performed on the patient that day. Cryolysis destroys excessive tissue that leads to scarring and tightening of region. Cryoprobe, junction of soft, hard palate, lingual tonsil and or base of tongue, and flexible laryngoscopy performed if treating base of tongue, lingual tonsil. 2 components, palate performed using a mouth gag, tongue performed using a bite block and pulling the tongue out of the mouth, flexible laryngoscope used to confirm proper placement for base of tongue, lingual tonsil. Next slide, please. Now we will launch our next poll question. True or false, percutaneous irreversible electroporation IVR of liver is new code 55877.
All right, we'll give it a few more seconds. Okay, Shelly, it looks like most people said true.
The answer is actually false. The new code 55877 is for prostate, and the correct new code for liver is 47384. Next slide, please. Now we will go to the orthopedic surgery section. We will be going over new codes for carpometacarpal joint arthroplasty, limb lengthening, shortening femur, limb lengthening, shortening tibia, and percutaneous decompression of medial nerve. There are revisions for hip and pelvis arthrodesis surgery section and deletion of code for knee arthroplasty and femoral osteoplasty that we don't have the time to go over, but encourage you to review in the AMA 2026 CPT manual. Next slide, please. CMC joint arthroplasty, 1003T, rationale for new code. It's established to report CMC joint arthroplasty for the first CMC joint prosthetic replacement. It involves the replacement of the trapezium cup at the distal trapezium and proximal metacarpal. No codes available to report this service before 2026. It's a multi-step procedure, duration, and implant technology with replacing the trapezium cup in the first CMC joint. Next slide, please. Limb lengthening, shortening femur, new code 27458. Established to report osteotomy femur unilateral with insertion of an externally controlled intramedullary lengthening device, including iliotibial band release when performed imaging. Describes a new externally controlled intramedullary lengthening device used for treating limb lengthening inequalities due to infections, trauma, or congenital conditions. Next slide, please. Limb lengthening, shortening tibia, new code 27713. Established to report osteotomies tibia, fibula when performed unilateral with insertion of externally controlled and lengthening device, including imaging. Identifies the procedure of cutting a bone to correct deformities, realigning bone structure, or lengthening the bone. May be performed to treat conditions such as arthritis, inconsistencies with lengthening of the long bones, or malignant issues. Next slide, please. Percutaneous decompression of medium nerve, new code 64728. Extracranial nerves, peripheral nerves, and autonomic nervous system, and neuroplasty. To report decompression of the medial nerve at the carpal tunnel performed percutaneously, an alternative to and distinct from traditional endoscopic or open surgical approaches, uses real-time ultrasound guidance and includes intracarpal tunnel balloon dilation to create additional space. Next slide, please. We will now be going over procedures in the general surgery section. We'll be going over new Category 3 codes for colorectal bypass sheath placement, multispectral imaging for burn wounds, selective enzymatic debridement, robotic lymphovenous and lymph node procedures, and thoracic irrigation. Next slide, please. Colorectal bypass sheath placement, new code 0967T. Transanal insertion of intraluminal temporary colorectal anemosis protection device, including vacuum anchoring component and flexible sheath connected to external vacuum source and monitoring system. The code improvements in technology developing flexible sheaths used to protect against colorectal anemosis leaks. The new code established to report colorectal bypass sheath placement, treatment following colorectal resection. Flexible bypass sheath is inserted transanally into colon close to anemosis site, creates a barrier to facilitate health, sheath anchored and kept in place by vacuum source. Next slide, please. Multispectral imaging for burn wounds, new code 0972T. Code includes system setup, acquisition, selection and transmission of images, automated report generated without physician and or qualified healthcare professional involvement. Code is intended for assessment of burn wound healing potential and differentiating non-healing from healing burn tissue. Procedure uses assistive algorithmic analysis of dataset. Assistive means the machine detects clinically relevant data, but does not analyze the data or generate conclusions. The device captures images of the wound, and the report provides outside measurements of the burn wound, evaluates and assesses information in the report, interprets results of the report, and determines effects on treatment plan. Spectral signatures, different tissue components, such as hemoglobin, reflect and absorb this light in a unique way, creating distinct spectral signatures. It aids surgeons in intraoperative decision-making to debride effectively and appropriately. Next slide, please. Selective enzymatic debridement. New code 0973T, 0974T, 0975T, and 0976T describe selective enzymatic debridement of partial thickness and or full thickness burn eschar. New codes require general anesthesia or moderate sedation that is separately reported and includes initial wound cleansing, preparation, and topical application of a selective enzyme agent, repeated dressing soaks, mechanical debridement, and patient monitoring. The work involved with this procedure was previously reported using unlisted code 17999. The service involves using enzymatic burn eschar removal drug to achieve rapid, consistent eschar removal, assists in initiating wound closure, and prevents further complications. Procedure requires general anesthesia and moderate sedation. Next slide, please. Here are the new codes and their descriptions for selective enzymatic debridement. Next slide, please. Robotic lymphovenous and lymph node procedures, new code 1019T. New code 1019T, lymphovenous bypass, including robotic assistance when performed per extremity. New code established to report lymphovenous bypass on an extremity. It includes robotic assistance to perform procedure if used. Procedure includes both microsurgical bypass of the lymph node and vascularized lymph node transfer. Certain lymph node procedures, such as 38303, 38790, and 38900, and microsurgical technique 69990 are inherent and may not be separately reported. Next slide, please. Thoracic irrigation, new code 1021T. New code 1021T, active thoracic irrigation. No code existed to report this service for active thoracic service. The procedure involves pleural irrigation using saline solution through catheter placed in the pleural cavity to clear accumulation of excess fluid buildup. Excess fluid is drained using either the same catheter or another catheter. Next slide, please. Now we will start the procedures for gastroenterology. During this section, we will be going over endoscopy with directed submucosal injection and bulking agent into the anal canal, upper GI blood detection, autologous cell therapy anus, and percutaneous electrical nerve field stimulation, and barostat and anorectal management. Next slide, please. Endoscopy with directed submucosal injection of bulking agent into anal canal. New code 0963T, endoscopy with directed submucosal injection of bulking agent into the anal canal. Parenthetical note, do not report with code 46600 endoscopy diagnostic, including collection of specimen by brushing or washing when performed. When a patient's anal sphincter is not as tight as it used to be, they can present with fecal incontinence. When this occurs, the surgeon can inject a bulking agent on each side of the anal canal. The picture on this slide shows the before and after the injection has been performed to narrow the anal canal opening. The procedure can be done outpatient and is less invasive than other corrective procedures. Parenthetical notes have been added to existing codes, and an incorrect parenthetical note under existing code 0373T that directs for this procedure for endoscopy with directed submucosal injection of bulking agent for fecal incontinence, use 46999. This should state use code 0963T. Next slide, please. Upper GI blood detection, new code 0977T. Upper gastrointestinal blood detection sensor capsule with interpretation and report. The patient swallows the capsule, which can be performed in the office or outpatient setting, to identify positive upper GI bleed in the stomach only. Once swallowed, the capsule senses blood and sends the information in real time to the receiver. This is different from the wireless capsule that would send images over hours. Next slide, please. Autologous cell therapy anus, new code 1001T. Autologous muscle cell therapy, injection of muscle progenitor cells into the external anal sphincter, including ultrasound guidance when performed. Code 1001T describes these steps. Harvest the cells from patient's thigh muscle, isolate and expand muscle progenitor cells in the lab, 12 injects of progenitor cells into the external anal sphincter. The procedure can only be performed once in a lifetime. The goal is for the injected progenitor cells to form new muscle fibers, restoring some of the structure and function of the damaged anal sphincter. Next slide. Percutaneous electrical nerve field stimulation, new code 64567. Code 64567, percutaneous electrical nerve field stimulation, cranial nerves without implantation. Code 0720T has been deleted, and code 64567 has been established to report PENFS of cranial nerves without implantation of the neurostimulator device. Code 0720T represents stimulation of the cranial nerve field branches through percutaneous periocular placement of a non-implanted electrical nerve field stimulator device. Guideline language placed within the subsection highlights that this procedure does not target a specific cranial nerve, and it is not an invasive implanted stimulator device. The PENFS is most used for pediatric and adolescent patients. It's a non-surgical device that works by sending gentle electrical impulses into cranial nerve bundles located in the ear. This stimulation targets brain areas that process pain and help reduce function abdominal pain associated with irritable bowel syndrome and functional dyspepsia. The system is a 5-day, 120-hour treatment, typically worn for 4 consecutive weeks, and a new device is applied weekly. Evaluation and management codes are not reported, but potentially could be with the initial and last visit. Everyone should confirm with patient's carrier. Next slide, please. Barostat and anal manometry, new codes 91124 and 91125. Rationale for the new codes: review use of 3 code pairs for services that were billed by the same physician on the same date of service 75% of the time. In response to this analysis, codes 91120 and 91122 were deleted and 2 new codes were created. Code 91124 will be used to report a barostat, and code 91125 will be used to report 5 anorectal manometry. Several parenthetical notes were added following these codes. Next slide. We'll now go into urology procedures. There were significant changes in this section. We will be going over new, revised, and deleted codes for laparoscopy prostatectomy, prostate biopsy services, hysterourethoscopy, transurethral robotic-assisted water jet resection of prostate, and laser coagulation of prostate. Laparoscopic prostatectomy. Before 2026, code 55866 was reported with code 38571 if full lymph node dissection is performed. As of January 1, 2026, new codes without LND, with limited LND, and with complete LND. The new codes added to bundle services commonly performed together. New codes have been added to report laparoscopic radical removal of the prostate gland with limited and bilateral pelvic lymphodectomy. Code 55867 describes laparoscopic simple prostatectomy specific for benign prostatic hyperplasia, not cancer. And code 55866 update to a parent code. There are many new revisions added to parentheticals for laparoscopic prostatectomy to provide users with instructions regarding exclusion of services duplicated within other codes and should be referenced in the AMA book. Next slide, please. Prostate biopsy new codes changes clarify intended reporting for diagnostic ultrasound services versus imaging commonly provided for prostate biopsies. Changes were made to the code set to bundle services that were commonly provided together into the individual codes that identified the type of prostate biopsy procedure provided. Oh, sorry. And these code, oh, sorry, I'm so sorry. Include this with systemic and targeted biopsies should not be confused with prostate saturation biopsy 55706, which is a unique procedure utilizing a template grid to take biopsies at 5 millimeter intervals through the entire prostate gland, with each specimen labeled with the location where the core was taken from. Next slide. Code 55707, transrectal ultrasound. It includes the ultrasound-guided biopsy of the prostate, the transrectal approach. It utilizes sextants, specific division of the prostate gland into designated portions that are each biopsied according to the specific section using ultrasound. Excluded from the reporting with any other prostate biopsy or ultrasound imaging procedure. Users directed to code 0443T for real-time spectral analysis of prostate using fluorescent spectroscopy, and codes 55708, 55709, and 55710, 55711, and 55712. All include these components with some additions. Those are for 55708, the transrectal use of MRI ultrasound fusion biopsy of an initial lesion of interest, excluded from reporting with any other prostate biopsy or ultrasound imaging procedure, and if any additional lesions of interest also biopsied using the MRI ultrasound fusion technique, add-on code 55715 is reported for each additional lesion biopsied using MRI ultrasound fusion technique. 55709 includes transperineal. Next slide. Prostate biopsy new codes continued. 55710 includes the use of MRI ultrasound fusion biopsy of an initial lesion of interest with transperineal approach. If additional lesions are targeted using MRI ultrasound fusion technique, then code 55715 may be reported for each additional lesion. 55711 is transrectal approach, MRI ultrasound fusion guidance for an initial targeted lesion only. And 55712, transperineal approach, MRI ultrasound fusion guidance for an initial targeted lesion only. If additional lesions are targeted using this technique, then code 55715 may be reported for each additional lesion. 55713, prostate biopsies using CT or MRI, all sextants sampled in bore, includes biopsy of additional lesions that is targeted in addition to the sextants. If other lesions are targeted using in-bore technique, then code 55715 may be reported for each additional target. 55714 is a prostate biopsy using CT or MRI. Procedure only involves biopsy of individually targeted lesions that are done in bore, includes biopsy of initial lesion that is targeted. And 55715 is reported for any procedure where an additional lesion is performed in bore or for additional MRI ultrasound fusion targets. Parenthetical note identifies main procedure that this service may be performed in conjunction with. Next slide. Cystourethoscopy with commissurotomy and drug delivery rationale. Code 0619T has been deleted to accommodate the new code. New code 52443 has been established to report treatment of obstructive benign prostatic hyperplasia via cystourethoscopy and balloon catheters. Code 52443 includes language that clarifies the efforts of the service, use of the initial balloon to perform the commissurotomy, use of additional drug-coated balloon to maintain the commissure, including imaging. Next slide. Transurethral robotic assisted water jet resection of prostate. Code 52597 was established to report prostate ablation using the transurethral water jet. Code 0421T and its associated parenthetical notes were deleted. Treatment method for benign prostatic hyperplasia. More descriptive language has been included within the descriptor of code 52597 to better describe the services that may be performed as part of the procedures, including intraoperative planning to confirm the needs of the resection according changes to the target area, postoperative bleeding control, openings made for the vas deferens and medius, and cystourethoscopy and dilation of the urethra and erethotomy. Next slide. Laser coagulation of prostate, deleted code. Code 52547 has been deleted due to low volume of reporting, lack of manufacturing of the device used for the procedure. All associated instructions for this code have been deleted from the code set. Next slide. Benign prostate ablation with HIFU, male genitalia system. New code 0950T, ablation of benign prostate tissue transrectal with high intensity focused ultrasound HIFU, including ultrasound guidance. This code is used to report use of high intensity focused ultrasound to ablate benign prostate tissue. It differs from code 55880, which is used to report ablation of malignant prostate tissue, and also helps differentiate prostate ablation procedures that may require magnetic resonance image guidance to perform the procedure. Next slide, please. Integrated tibial nerve stimulator rationale. New code 0988T and 0989. Current category 3 codes exist to report open subcutaneous and subfascia insertion replacement and revision removal of integrated tibial nerve stimulator systems for bladder dysfunction, but no code for subcutaneous and subfascia placement. Code 0958T and 0989T established to report subcutaneous and subfascia insertion or replacement or revision or removal of integrated tibial nerve stimulants. These are exclusionary parenthetical notes that have been included to restrict reporting specific codes with these codes and should be reviewed. Next slide. Low energy urethral lithotripsy, new code 0991T. What is it? It is used to report use of low pressure ultrasound lithotripsy to treat urethral calculi. The procedure uses low pressure ultrasound to activate microsphere Negatively charged gas-filled microbubbles. The microbubbles expand and collapse, causing microjets that erode the calculi. Next slide, please. Urethral autologous cell therapy, rationale, new code 100T. Code 1000T is used to report administration of muscle progenitor cells into the urethral sphincter for urethral autologous cell therapy. The muscle progenitor cells is a suspension that includes tissue harvested in the vastus lateralis upper leg that is concentrated, cryo-reserved, and currently used as urethral autologous cell therapy. The treatment involves preparation of the suspension for usage and transurethral injection of the suspension into 9 injection points along the urethral sphincter muscle anatomy. Cystoscopy and post-void residual ultrasound to confirm accurate application of the therapeutic treatment is included when these procedures are performed. Various parenthetical notes are throughout the code set. Next is evaluation and management. And since we are over, you are welcome to look at these slides at your own. And I would encourage you to review all of the parenthetical notes and the appendices P and T for additional context for digital medicine.
Shelly, did we lose you?
No, I shared that since we are
sorry.
so over time that they can please reference these slides on their own, and I encourage them to review all of the guideline changes and the appendices for the digital medicine.
Perfect. Okay, we have 1 or 2 questions to get through. For gastroenterology procedures are separate from colonoscopies themselves, correct? All the gastro procedures that you mentioned are separate from colonoscopies, correct?
Yes.
Okay. And then another came in, are the CPT codes discussed today for surgical procedures? Are there any codes relevant to ambulatory care or multi-specialty?
I will take that question, Jordan. The codes discussed today, they came directly, I mean, they're obviously from the AMA, and as far as settings where they're appropriate, that they vary. So there was a wide variety, and we'd encourage you to look for what may be appropriate for your particular setting. As Shelly had mentioned, there's a couple slides that were related to the evaluation and management. There's cardiology, and that may be performed within catheterization suites. So it was just a wide variety of the changes that were part of CPT.
All right, so I think we're going to go ahead and close out. I know that was a lot, everyone, so I really, really thank you for attending. Thank you, June and Shelly, for handling this. So be on the lookout for the recording of the webinar, the certificate of attendance, and then also the slide deck will be available to you. And then if you have any questions related to IMO Health or any of our solutions, just contact your IMO client representative at sales@imohealth.com. But thank you again, and I hope you have a great rest of your day.